Hello, everybody. This is the webinar of the ETIN Task Force, the Task Force for Emerging Technologies and Innovations in Neurosurgery. I'm Nikolay Gabrovsky, and we are here together with Dr. Stefan Motto from Switzerland to present you the webinar of today, the topic of today. We have been waiting for Dr. Maurice from Mayo Clinic to present us the state of art in 3D printing. Unfortunately, we have just received a call that he won't be able to join immediately. So let me check. So he won't be able. He has some kind of emergency, and he won't be able to do this presentation. But despite that, we decided to make a small overview of 3D printing. This is a well-known nowadays technology, but there are some interesting applications in neurosurgery especially, but also in craniofacial surgery that we can discuss. And we will discuss emerging technologies and innovations as a whole. So I think that this will be an interesting possibility for us to make an overview of what is going on in the field of neurosurgery, and especially regarding innovations. Innovations, if you look at the Merriam-Webster dictionary, you will see that these are a new idea, method, or device, a novelty, or the introduction of something new. If we ask ChatGPT, we can receive a more thorough, more complicated, more interesting response. And this is that innovations is the process of creating and implementing new ideas, products, services, processes, or method that result in a significant improvement or a novel approach to addressing a problem, meeting a need, or achieving a specific goal. It often involves taking existing concepts or technologies and finding new and creative ways to apply them, or it may involve entire groundbreaking ideas. So it's much more complicated, but if we have to look at the key characteristics of what innovation is following ChatGPT, we can say that there are probably 10 most important points. These are creativity, problem solving, implementation, change and improvement, adaptation and evolution, market and competitive advantage, type of innovation, social and cultural impact and collaboration, and finally, risk and uncertainty. I will show you this diagram that is presented in the National Academy of Sciences, Engineering and Medicine, and this presents in the whole process of curing people. In fact, we start with the patient experience, the first problems that the patient may have with the engagement with the healthcare system. Then we have a very complicated circle of information integration and interpretation, with working on the diagnosis and with forming, gathering all this information and forming some kind of therapeutic attitude. So we have a clinical history and interview, physical exam, referral and consultation, and diagnostic testing. Then we have communication of the diagnosis, a treatment plan that is applied, and we have an outcome if the patient is cured, or we come back and restart all the system. So as you can see, this is a very complicated process, and at every single step of this process, we can have an innovation. There is regarding innovations, there is a Gartner hype cycle who is relative to every single innovation. So there are two main axes. These are visibility and time. As we can see in the beginning, we have a very big, important rise in the visibility for a very short time. This is the technology trigger. Then we have a peak of inflated expectations, and then we have a decrease in the visibility with time. This is thorough of disillusionment, slope of enlightenment, and finally, we have a plateau of productivity. So this is something that involves all possible innovations, and is more or less relevant to all innovations. So if we look at the hype cycle of the top 50 emerging digital health trend, this is an analysis made by Bertrand Mesco in the future and the medical futurists. You can see that there are some keywords, 50 more important keywords in the field of healthcare. Of course, we have 3D printing, artificial intelligence, digital health research, e-patients, digital health design, robotics, etc. So these are the main fields that will pass through this hype cycle that I just presented. Of course, we can see that there are a lot of investment in the field of AI, and probably this is the most burning, I would say, topic, not only in the field of healthcare, but also in every field of our life. So definitely healthcare and AI will join together to make the management of our patients completely different in a very short period of time. This is also supported by the numbers, and the numbers shows that the investment in AI and especially in large language models is really huge, and we have more and more people that are attracted in this field. I will come back to a very hot topic for the last few years, that was walking naturally after a spinal cord injury. In fact, this is the topic of brain-spine interface that is very important, something very innovative, and I would say not innovative by itself, but including a lot of innovations of every single step of this process. This was a publication in Nature that was made in 2023, and this is a huge team, mainly from Switzerland. And finally, I think that we had an enormous step ahead regarding people that have spine injury. We know that a lot have been done, thousands probably of scientific works has been dedicated to the restoration, neurorestoration, and restoration of the possibility of people to walk after a spinal injury. This is one very interesting direction, which include the bypass of the zone of injury and bridging the cortex, the motor cortex, to the healthy, I would say, to the inferior part of the spine where there is no injury. And thanks to AI, make modulations that will transmit the signal from the cortex to the spinal cord and will permit the spinal cord to emit signals to the muscles and make them imitate a walk. So consecutiveness of muscles contractions that finally will present a walk. This was a huge step ahead, and the fact that Elon Musk also started, both Neuralink started implanting this type of chips, similar type of chips, is very important, because in fact commanding whatever we want with directly from our brains will be a huge advancement for all of us. And of course, walking thanks to this bridge from the brain to the spinal cord is a huge step ahead. But as you can imagine, we can use these signals from our motor cortex to do a lot of different things, making a brain-machine interface, etc. So I think that this type of technology have a huge future. Thanks to the new technologies, thanks to the innovations, these new chips are so sensitive that they permit to acquire good signal even without implantation in the brain tissue. This type of electrodes can remain extradurally. This is very important regarding infections and other type of problems that this type of implants may have. So I think that the future here is really bright. So regarding this technology, I think that we are somewhere here in the beginning even of the visibility, of the rise of the visibility, and I think that we may expect a significant progress in the near future. 3D printing, this is a very interesting and I would say hot for the last decade topic. In fact, 3D printing is equal to additive manufacturing. This is something that has been invented in the 80s, but was so expensive in that period that only a few laboratories can afford this type of equipment. The idea of 3D printing is that we make the objects by adding layer by layer, one over the other, and finally shaping this 3D model. This is completely opposite to the usual ways of production, where we remove material from a bigger object to have our final wanted by us 3D model. So this is a completely different concept that is linked to adding new material and not removing material. Regarding 3D printing, we had a huge step ahead for the last 10 or 15 years, mainly by making all these systems very affordable. This was become possible thanks to the development of the computer-assisted design and the computer-assisted manufacturing. This type of software, of programs, has also been very expensive and affordable only for the richest companies or laboratories. And nowadays, you can have almost everything for free, at least as a basic level. Another important step was the development of different types of 3D printing technologies. We have the most well-known nowadays are the stereolithography, SLA, the fused deposition modeling, FDM, the selected laser melting, SLM, the selective laser sintering, SLS, and electron beam melting. Basically, the idea is, as I said on the previous slide, built layer by layer by different manners and creating the object layer by layer in a liquid, in a resin, thanks to laser or adding different type of polymers, but the result is the same. We deposit layers of material and we have finally a new 3D object. Of course, a huge advancement was the development of new models, something that gave us a lot of possibility, including in medicine, including in healthcare, including in neurosurgery. So in 3D printing, there are several fields that we can have advantage. Thanks to 3D printing, first it's the preoperative planning, mainly in vascular surgery, in tumors, etc. So we can make a preparation and stimulation of the upcoming operative procedure. We may have the 3D model in our hands. We can play with this model. We can think and pre-plan the operation. We can try to make some cuts and to make some steps from the operation, which is a huge advantage as we are watching now in sports. The skiers are preparing themselves mentally, running through the slope. So we can do the same with our operation. Another advantage of 3D printing and possibility of 3D printing is patient education. We can present to the patient what we expect to perform as surgery, to visualize, to help them and visualize the process, the tumor, the vascular pathology, and to explain them easier how we could cure them thanks to our the operations that we are planning. Of course, a huge...
Nikolay, I just want to let you know that I was here. I don't want to interrupt you, but I just wanted to let you know.
Oh, Jonathan, okay. Can you keep now? Can you continue now?
Oh, yeah, thanks.
Okay, I will stop sharing this. I think that I made a nice introduction of 3D printing.
That was beautiful.
Please do it.
I was like,
and I'm very glad, Jonathan, that you could join us. Thank you very much. There is a huge time lap between Mayo Clinic and Europe. Thank you very much for joining us. And I think that you take over and give us the overview on this topic. Thank you very much, Jonathan.
Yeah, thank you. Sorry, I was a bit late. We had some trouble finding the Zoom link. It was in Mayo security somewhere. So let me see. We select a window. Okay. Let me know when you can see see a slide. Do you see a slide okay?
No, you have to double click to enter full screen mode, but it's a black one.
Oh, you don't see the slide. Okay.
Now we see it.
You see it now?
Yeah.
Is it changing?
Yeah.
Okay. So I think we'll skip some of the objectives, but one of the main things that I want to talk about, first of all, thank you for having me and thank you for your patience. It's always a bit of a challenge in these things. And unfortunately, I was doing cases this morning. So one of the first things that I want to talk about is much of the innovation that I want to show is driven by a collaborative effort at Mayo Clinic between us as radiologists and engineers and surgeons and the various types of technology we'll talk about. If you don't know much about Mayo Clinic or have never been to Mayo Clinic, we see about 1.8 million patients from about 150 countries in all 50 states, mostly for complex care here in the middle of Southeast Minnesota, which if you've never been to the United States, I can assure you it is not a major city. We're a town of about 100,000 people. But what people I think really come from are integrated teams of people that are constantly working together on a daily basis to provide the best possible care. And I started doing this in 1999 at NIH, but then I came here and started doing it here about 2004. And really, this tool of additive manufacturing or 3D printing parts, it's just one more tool in this multidisciplinary group of people that have to solve complex problems, of which one is neurosurgical problems. We're not like a couple printers in a room. We were at one point, but Mayo has this culture of innovation to the point that very early in Mayo's history, they hired engineers. So we have about 70 engineers that have a pretty big footprint that do anything from mechanical to chemical engineering without a big engineering school. Essentially, they work for Mayo Clinic and have been that way since the very beginning. So in the early days, we were designing things on their printers, but over the years now, we're fully integrated into the 5-state enterprise. So we have about 4,000 something physicians in Rochester, and we've got about 8 across the enterprise with 42,000 clinically facing employees. And at any time, anyone can just place an order in the electronic medical record. And it can be something as complex as chondrosarcoma of the pelvis with tumor margins and custom implant. Like we're fully integrated to Epic, which then leads to an imaging protocol that's specific for manufacturing. It goes through a series of manufacturing steps all the way to 3D printing, delivery to the OR, and through billing, which we'll talk a little bit about. If you don't know much about this, we start with imaging. So imaging has been crucial to the advancement of this. We import them into one of 2 FDA-approved softwares. We then segment them, which means pull out the piece that we want. And if you want multicolor or multiple pieces, it's not like radiology imaging. Each one of those pieces has to be its separate CAD item, and then we send it to one of 46 different printers. So when people say, what printer should I get? How much should I buy? Well, how long does it take? How much does it cost? It really depends. So we're taking complex cases like this, and if you want the head to come off the spine, and you want the ribs to come off, and you want the trachea, and you want the arteries, and you want them all as separate printable items, well, they have to be separated using segmentation, which means that each one of those is a watertight CAD. We do things to that CAD model, either minor or what's called major modification. Sometimes we're adding rods and pediatric bones. Sometimes we're adding magnets because we want to be able to remove anatomy or take anatomy off, or we want to build custom medical devices to that anatomy. And, we've got a whole slew of different printers. So there's no such one thing as 3D printing. It's 7 ASTM technologies, and some do clear, some do color, some do photorealistic color. Sometimes we need to have flexible things like when we're doing pectus excavatum cases or landing stents in hearts or doing complex endobronchial cases or complex aortic reconstructions. We do a whole host, a few thousand sterilizable devices that screw on the bone for complex craniomaxillofacial resections, orthopedic oncology, and skull-based surgery. So we're printing things that aren't just preoperative planning. We're printing medical devices that lead to things all the way to custom titanium, which brings to finally there's titanium printing. Now, most of the titanium printing happens outside of Mayo Clinic, but we do have a printer in-house. We're working towards some custom implants, but really, you have to do a lot of that because the printer starts at $1 million before you even bought a grain of titanium. So, and it's an incredibly long, laborious process to qualify custom titanium printing. And over time, really, the manufacturer, which used to be separate from the hospital, had become the hospital. So the Society of Manufacturing Engineering and the American Society of Manufacturing Engineering we've come up with this term called point of care manufacturer. It's something that we can talk about with standard terminology. It's something that we can talk to the regulatory bodies, the European regulatory bodies, as well as the FDA, as well as the China FDA. And now the hospital is a manufacturer, which brings up a whole host of questions. Because if you're going to use a lot of different technologies, for example, this uses 4 different technologies in order to do cranial vault reduction size in this case, and how is that going to be regulated? What type of QMS system do you have to have in place in order to do this accurately, not just do it? There's a whole host of things that have to be removed from the printing before it looks like a 3D printed project. So there's a lot of support material, like in this case, that has to go into a lye bath. So that's material that shouldn't go on a human being, but it doesn't come out of the printer like that. There's water soluble support materials. There's powders for selective laser sintering that have to be vacuumed away to find your piece. There's scaffolding that has to be removed. There's alcohol washing. There's photo curing. All of these things that have to be done in order to get your printer out. So it's just not the printer. There's a whole bunch of post-processing that nobody really talks about, but is critically important, particularly when you get into biocompatible, sterilizable objects or implants. We started back in 2003 with sets of conjoined twins. That's when I was a resident here, and a pediatric radiology and I started doing this. And this was one of the first things we printed in-house was this liver, and this picture that is shown with these surgeons, that's Chris Moyer since retired, there's going to be 50 people in a conjoint case, and there's going to be somebody, though, that has to make the cut through the liver or the body wall. In this picture of using a physical life-size model to discuss with a multidisciplinary team, this happened this morning, like down in the OR. This picture has been replicated throughout the time that 3D printing has been used in medicine. And as these girls have grown over the years, and they certainly have grown, they celebrated their 10-year separation anniversary, they've graduated high school now, our lab has significantly grown. So the first place we grew, though, interesting enough, was when Tony Stans, one of our spine surgeons, does a lot of congenital spines, he said, "Oh, I saw the spine on that model." And of course, spine surgeons really don't care about conjoint chest and pectus. He says, "I do these complex congenital cases. Do you think we could work on some cases together?" So really, we went from twins to spines. That was the first kind of, where we're getting 30, 40 cases a year, planning screws into complex congenital scoliosis, doing more complex cases. Navigation is great, but navigation is not perfect either. So having a forest view of the spine, like while you're doing some of these more complex cases, was important. And we're a destination medical center, so people don't fly all the way to Mayo Clinic because they have simple problems. They usually come with complex problems. And sometimes you're just making a model to think like, how could I even begin to start to fix this? Should I fix it? Can I fix it? What type of osteotomies am I going to make? Just to be able to think about it before you've even agreed that there's something to do, to be able to show people and say, how would we start to approach this? We have to take all the hardware out. We'd have to, it's fused in all these places. And what we guarantee that we give to the surgeon is that is diagnostically accurate. It's not a pretty picture. It's made on FDA-approved software. It's guaranteed by a radiologist that works up here full-time all week long, doing nothing but assuring that the segmentations are accurate. And early on, it was just a lot of, I want to see the forest through the trees, that I'm over here looking through small incisions or doing something less invasive, or I'm doing a certain level, and I still want to have this forest view with me. So this concept of like, don't miss the forest while you're looking at the trees was really important in the early days, because I'd say, well, you've been doing this a long time. What makes this so interesting to you? And they'd say, well, I'm looking through a little keyhole and I can't see everything. And as good as I am, and as good as the navigation is, sometimes it's not perfect, So in about 2012, after about 8 years or so of just doing this nights, weekends, along with my other neuroradiology jobs, I was building spine tumor ablation at the same time. We really needed some engineers. So we came up with this concept of not the 70 engineers we have that are doing long-term projects, but clinical engineers that would be on the surgical team and be on the radiology team. And this would be their prime focus. The first thing you learn is you can't find these people because you have to teach them radiology, anatomy, pathology, multiple surgical disciplines, just not spine. They do everything from congenital heart all the way up to skull-based tumors. They do pectus excavatum 1 minute, cranial synostosis the next minute. And over time, what we've been doing is building these clinical engineers into the system so that they're just part of the fabric. So manufacturing is part of the fabric, but having an engineer above the OR, we're like right now on 5 flights above the OR, We had 3 surgeons up here already this morning doing complex cases, designing, drawing on things, doing virtual surgical planning, and then just going back down to the OR. And having that proximity to very busy surgeons has been really crucial. There's been 2 things that have been really important of our advancements. 1, we're in the hospital. 2, we're run by physicians. 3, we put engineers on the surgical teams, but mostly we're right where they work and they can just order it like anything else. And we need 5 minutes of their time. All the way up to complex cranial synostosis reconstruction, we need 5 minutes of your time. Come and draw a couple lines. We will do the rest for you. And the door is open, and we don't ask you how much money you have. The door is always open to any surgeon to come and ask a question about manufacturing. And the ORs are down here at St. Mary's. We have 2 campuses. And that's all changing right now because we're doing a $5 billion construction over the next 3 years. But we're upstairs, right above the OR. So people come in between cases during anesthesia, go over anatomy with us, do virtual surgical planning. And then from the spines, we had patients that were coming with tumors in the spine, obviously, which, it's very difficult to get a negative margin. What are you going to do with primary bone tumors? How do you describe this to the patient? What are you going to put in its place after you resect it? And people were asking, can you make the clavicle removable? Can you do a virtual resection? We're just having these conversations between the surgeons and us. And once we started getting tumors, there was really no going back. So then anybody who had a tumor was starting to come to us for service. So there's mediastinal tumors or mandibular free flaps or maxillectomies or renal or pediatric. And because we're this manufacturer in the hospital, we're able to provide service to every single group of people. And if you followed many of the industrial revolutions, we're just getting out of 4 and going into 5. And we're on the cusp of distributed manufacturing with smart factories. So 3D printing's been around since the 80s. I started in the 90s. Scott Crump, who developed FDM's wife, the first printer they made was for medical, but it just wasn't ready yet. And now we're at the point where we're almost getting ready to deploy like AI segmentation, autonomous manufacturing, because distributed manufacturing allows you to have several different ways to do it. Like we have all on premise. So if you come to Mayo Clinic, there's anywhere between 47 and 50 printers. There's some people that have some people have just partially printers on premise. We feel it's really important to have the whole staff, all the printers, all the manufacturing here, up to really complex titanium. We focus on anatomic modeling, so we guarantee this is the tumor margin. We guarantee that we'll give you an R0 resection. We guarantee from MRI, CT, and PET that you will not cut into the tumor. We do virtual surgical planning, whether it's some complex pedicle screw trajectory planning, whether it's virtual surgical planning to do fibrous dysplasia reconstruction, whether it's resecting osteosarcomas and doing knee sparing, complex cadaver allografts with intussuscepted fibular free flaps. We do all of that guided work up here to be able to do guided resections, which we'll get to how that relates to, resecting meningiomas and things in a day. We do all the external and internal hemipelvectomies guided out of here, again, because we have the protocols that are geared for manufacturing. We have the engineers that design all the guides. We have the surgeon who comes up and says, this is my exposure. This is what I can get. And then we also run our 3D data through augmented and virtual reality. And we have a very large educational push out the back end of people who then take our data and cases and turn them into enterprise-ready educational tools. So one of the things I like to show of how 3D printing helps is like you see a patient and you're really starting over on your left and you want to get to somewhere on your right before you go to the OR. And I think that's one place that 3D printing has helped. So if you have a patient like this that comes, that's found to have a very large jugular tumor that's extremely vascular and it's a paraganglioma, and they've got a CT and they've got an MRI, they might have a balloon test occlusion, they have a swallow study, they might have a PET study. They've got so much information that you have to digest in order to make a surgical plan. And if you're 10 years in, to your practice of skull-based surgery, then that's great. You've come a long way and accustomed to doing this type of work. But when you're starting out, boy, it's difficult to teach this. It's difficult to train in this. And then it's difficult to then start on your own with a very steep learning curve of replicating what those before you have gone and done. And I think giving people binary life-size tools like this to say, this is what you will find. This is the approach. We can simulate a suboccip. We can simulate a far lateral. You can say, am I going to come through the neck for this portion and talk to ENT? How am I going to get the cranial part out? You can take the mandible off, we can put the mandible on, we can print in multiple different technologies, but you can look at this in several different ways. And what you're not doing is looking at 15,000 images on the CT scan, and you're not looking at the next 3,000 MR images. You're looking at a life-size patient-specific model, who then you also have to talk to a patient about of what you're going to do for the patient. So patient education is, any model that's done before the surgery is always used for patient education, because there's almost no way for even other physicians to understand this, let alone someone who you're going to have to operate on. So it allows some vehicle of communication between just not the patient, but also the clinical team. So if you're working with ENT and you have a new ENT relationship, and it's not someone you operate on in 20 years, or if you're resecting very large tumors and you want to show the team, hey, what we're going to see is the tip of the iceberg, but there's a lot more under there. It goes back to this concept of, you might be looking through the microscope, but there's a lot going on under there. So the models really provide the big picture view, whether you're going through the robot, whether you're looking through the microscope. You say, if I see this, this is where I am, and that's where the surrounding anatomy is, which allows people to feel more confident, and more confidence leads to faster surgeries. RORs are about $80 to $100 a minute. We save on average 90 to 120 minutes in every craniomaxillofacial case. In skull-based cases, we've tracked blood loss savings, saline savings, retake back to the OR savings, plate fixation and ortho savings. All of that leads to a really nice value equation for us, because even though it costs money to manufacture this, that all of the savings are led into the OR. There's been a lot of technology advances in imaging, and I, at my heart, even though I treat spine tumors with cryo and things, I'm a neuroradiologist. And the advances in imaging that allow us to do something like photon counting scanning, all of those technology convergences have also allowed us to advance manufacturing from better imaging. So now that we're in the photon counting phase and we can see things at microscopic, not microscopic, but very small vessels, very small nerves. You want to know, hey, where's 4? Where's 6 in relation to this tumor? Where's 7 and 8? These advances in imaging technology, which have allowed us to see things in a much greater way, have allowed us to manufacture things even better and to start to show people anatomy that they couldn't see. So every advancement in MRI, whether it's deep learning, AI algorithm, denoising, bolus counting, all the things that's happening in the AI inside the scanner, ZTE, synthetic CT, has allowed us to manufacture things and co-register things. So co-registering MRI and CT used to be just a horrific pain, but as we get advances in these images and we get time of flight images and GAD bolus MRVs and flat panel CTVs during the rotational angiogram, and all these advances can then come together to allow us to take the cone beam, to allow us to take the rotational angiogram, to allow us to take the MR studies and allow us to put them together. So now that we're building tools and we're building AI segmentation tools, but we're also building tools that can do cross-modality, cross-phase, in-modality, co-registration, so that we get diagnostic models, so that when we send things like this to the operative room, and whether we're doing augmented reality overlays onto the skull or we're 3D printing models, you can rest assured that there's not, because of the advances in GAD bolus venography or cone beam CT venography during the digital rotational angiogram, we get like best-in-class data, which allows us to manufacture the best-in-class digital twin or create the best-in-class digital twin that we're then going to do overlay during augmented reality. Or sometimes we do both. We have an augmented reality overlay during pinning, maybe during the craniotomy planning, and then we have the 3D printed model that's in the field. We do a lot of great images, and people say, why can't you just look at the images? We make all kinds of fantastic images, and the images aren't life size. They're as big as whatever. If you're watching this on your phone, the images are as big as your phone. And one of the things that manufacturing has helped with is haptic perception, aiding in comprehension. So since every one of you, since you were born, have been touching things. You've been, if you CT scan a coffee cup, you have no idea what it is. If you hold a coffee cup in your hand, you don't even have to look at it because you know exactly what it is. So this idea that haptic perception, the homunculus, the size of the hand and the sensory level of the hand is driving comprehension has been critical to this, because you say, what makes this better than the imaging? It's the ability to physically touch this. And we see it. 15% of the time we change the surgical approach to all sorts of tumors. And it's people physically handling, looking at it, touching it, moving it, not looking at a stack of images, but looking at something they're going to go operate on and the size they're going to operate on. As we get better imaging, we're trying to get better AI algorithms to do this co-registration for us so that we can get to the place where we get these images, and we get robust thin section volumetric MR. We can then segment the MRI and the CT more robustly. And no one software package does this, but be able to get this in a format that we can then robustly provide anatomic models. We've been doing some innovations in navigation with Dr. Lee. So some of this stuff I want to say it cross-pollinates. By having a big center that does every subspecialty and not just neurosurgery, it allows us to take one ideas from a specialty and translate them into other specialties. I'll get to that in a minute, but I want to just talk about it here for a second because cross-pollination is such a big part of what we do. And our AI algorithms that are doing things for us in the radiology world or in the manufacturing world are now going to the radiology world, because if you could provide this level of detail to every patient on every scan in a 3D render that everyone could have on their phone walking down the hallway, well, I think it would be dramatically different surgical planning. So yes, we're manufacturing, but sometimes we just want to get to this, to where we're saying best-in-class MRA, best-in-class MR neurography, best-in-class visualization, and we want it to happen fast, and we want it to be deployed on whatever device you have. So while we started with things like this is Mike Link, who many of you might know. He's one of the skull-based surgeons that we started doing skull-based resections with. And, these are some of the earlier color models where we'd say, yeah, there's a large chondrosarcoma that somebody did a small suboccip, now they're fused, that most of the tumor is still there. And we found this to be helpful in seeing the forest view and printing it out and taking the back of the skull off, seeing where the arteries are displaced, seeing where the nerves are displaced, and knowing all that before you get into the operative room. And then once you take it out, what type of defect are you going to have? So all of this advanced imaging has really led for us to be able to do better manufacturing, cross-modality manufacturing, multimodality co-registration to lead to best-in-class visualization and then best-in-class manufacturing. So imaging is really important. Moving on to class 2 sterilizable devices, I'm just going to say that we produce a whole host of class 2 sterilizable devices that get screwed on that are prolonged blood and mucosal contact. For every polymer, every powder, it costs about $200,000 US to validate that and do the 11 to 12 ISO standard tests. You have to say that what you're making, not what the raw material is, but what you're making is biocompatible, not cytotoxic, sterilizable, and we have instructions for use that the sterilizable committee has to make. So if we're going to do things like knee-sparing osteosarcoma resections or complex orbital-sparing maxillectomies, then we have to be able to do sterilizable printing. And we had to create a regulatory infrastructure that would allow a hospital to do this. So like this case where you've got this osteoblastoma down here at C4, where they're going to have a CT, they're going to have an MRI, they're going to have an angiogram, they're going to sacrifice that vert, if most likely. There's a lot of information to take in. And this is a place where we use clear printing because you can only see a little bit of the tumor and most of it is stuck down in the bone. So we use clear printing for that. But this is a fairly extensive operation with neurosurgery, or orthopedic oncology and neurosurgery, with ENT, dissecting out the ansa cervicalis, getting you down there. And eventually you want all of this planned out. And just not the planned resection, but you want what you're going to put in there planned. So there's an iliac graft that was planned from the patient scan virtually before the OR with a guide that makes it fit perfectly. So there's a guided resection. The vert has already been removed. It fits perfectly. It's from the patient's own bone. There's a greater chance of fusion. The great apposition has a greater chance of fusion. And it saves time in the OR and drives the better results. So this is that piece that's placed in there, and you can see it fits perfect because it was all planned before the OR. We do this collaboratively, so I treat aneurysmal bone cysts with doxycycline foams, but if there's myelopathy and epidural extension, then someone like Dave Daniels will go in and resect the epidural component. So us talking to each other is really helpful. The other thing that is really important in radiology protocoling is getting the right data. So for us to make models of this for like large exophytic spine tumors or sacrectomy tumors, if we want ureters, arteries, veins, portal veins, systemic veins, we need radiology protocoling. So we have radiology protocoling that's built just for manufacturing. It's completely different than diagnostic 3 mm slices. These are all volumetric, high resolution, multi-phase. Patients don't move on the scanner. In order for us to be able to do this, because the surgeon said, can you just show me, like, I can, don't show me the cartilaginous cap per se, show me the osseous component, because the question here was, do you have to take it out from the back? Can you just do this from the front? And there's going to be a GI guy in there to get you down there. There's going to be a vascular surgeon that might have to reconstruct the vasculature. And your view is from the front. So you can't see the forest. You want to know, where's the ureter? Where's the ureter on the right? Where's the ureter on the left? Where are the veins displaced? Which is even more crucial if they ran a post-radiated bed, like if they came from the outside. In order to do this, we have to have really good radiology protocols. So this is four phases. And if the patient moves on the table, it turns into a bit of a disaster because there's not multi-phase AI co-registration algorithms. And there's a lot of images, right? We all look at about 15,000 images. And really, this is what the surgeons want from us. This is nylon 12 color printing, which allows us to make these lattices so you can see through the tumor down deeper in there. That required, an innovation in additive manufacturing. But ultimately, this was used to say, oh, we're just going to do this whole thing from the front and we're not going to fuse her. So the vascular surgeon knows what's going to happen, the GI surgeon knows what's going to happen, the ortho-onc and neurosurgeon are working collaboratively together, and everyone has had that model at the multidisciplinary tumor board talking about step 1, 2, 3, what we're going to have to do to reconstruct the vasculature in order to have this young patient, in order to get this out, reconstruct her vascular, and then she leaves 1 with a nice tumor margin, but 2 with no posterior fusion. And the less metal you put in tumor patients, the better, because our images are limited in that. Some companies try and advertise that they like to do tumors. I would say it's a horrible idea. We've talked to the FDA several times for companies that were advertising this. There's nobody who knows the margins of the tumor yet. There's no AI algorithm that can show you osteosarcs, chondrosarcs, giant cell tumors, margins, because you need the MRI, you need the CT, and you need someone who knows what's normal and abnormal. So one company sent in this little green tumor to an outside person that then sent it to us, and we said, you're going to cut right through the tumor and you're going to have a 100% chance of recurrence. A number of times when we've done the spine surgery and they've been radiated, you might have to go back. So sometimes we're doing, like, if the femoral strut or the cadaver allograft breaks and you're in a post-radiated hostile environment in the spine, you'd like to know, if I see this is where that's going to be, or how far in front of me is this going to be, because now there's no more planes. Sometimes we have to fix what somebody else has done from the outside, or we have to go in and remove hardware, replace hardware, and how much you're going to correct. We change approaches, like I said, like about 15% of the time, it changes what approach we're going to do. So if this case, we're going to try and spare the contralateral S1 nerve root, or we're going to try and spare the contralateral sciatic and provide them guided resections in order for them to get everything out, but spare. So like little guides like this that look very simple are very important when we're doing these large sacral pelvic tumor cases, of which neurosurgery is a big part. For congenital scoliosis, we have several ways that people are working on this. Of course, there's tether systems, there's fusions, there's hemi and butterfly, and there's which vertebral body you're going to resect, which wedge you're going to resect, how much can you correct the curvature of, how you're going to put them on the table. A lot of these people have rib anomalies. So in this patient, they wanted to put rods on the ribs, but trying to do this through a small incision is incredibly difficult. So we took the radiology images, we created a life-size 3D printed model, and then we do this not too infrequently with our congenital cases if we're pre-bending stuff to fit in particular areas. So when you're looking down, that yes, we can provide pedicle screw trajectory guides, which we don't do a ton of, but we do sometimes. But when you're looking down through this little hole and you say like, oh, I want to know like where this rod is going to be in this little hole. Well, we've pre-bent everything to specification, and we provide this. Now we're starting to provide this in augmented reality. For these external, internal hemipelvectomies, these small little guides, it's a massive exposure, but that small little guide saves S1. So even when you're going to girdle stone and do an hemipelvectomy, you can see how precise this line is to spare her S1 nerve root, which is, provides her a different quality of life. So if we don't girdle stone it, we are doing custom implants, we then partner with Stryker or Synthes or one of those companies. We are working at custom titanium plates, but right now we're partnering with different med device companies, and we're doing all the planning. So there's a number of specific medical devices that come on the market, some of which we've helped co-develop. There's spacers. They're all custom. They're all compassionate use exemption. There's not a well-known line in the United States. Once we were able to start printing in PEEK and PEC, in PEC really it was Oxford Performance Materials, but we just put in 3 months ago, we just finally put in a PEEK printer. So there was a company, Comovis, that figured out how to print PEEK through FDM. It took them about 3 years and an acquisition to get through the FDA, but now they're through the FDA. And now the question becomes, can a point of care manufacturing facility like Mayo Clinic that doesn't manufacture, that doesn't sell on the market, that doesn't market, that just is the manufacturer in the hospital, can we produce this without a 510K clearance? So right now we're having a lot of legal discussions with the FDA, who has been an incredible partner over the last 11 years, because we do have robust quality control systems. Like, do we have to 13485 that room? Do we have to, like, what do we have to do in order to do this? We know we can do it safely with or without that. But because we've been doing this for, 20 years now. But the question comes, like, should this be regulated? And that question hasn't been answered yet. Like I talked about in orthopedic oncology and neurosurgery combo, which we work together here, there's all kinds of ways to take people apart and put them back together. And a lot of it was pioneered with Frank Sim and Mike Yazemski and people before us. And I used to ask them, like these are some of the earlier cases, for Frank Sim, and say, well, you were taking out the pelvis before there was a CT scanner. How could this possibly help you? And he says, yeah, but I don't know where anything is. I'm like figuring it out while I'm in there. So our ability to give them these guides and these tumors and these diagnostic models that allow them to do things like an L5 corpectomy with vascular surgery, with GI surgery, with neurosurgery, and be able to have pre-bent rods, pre-placed things. That's all incredibly helpful because you know it all before you go in. So we do a fair number of spine tumors, paraspinal tumors, skull-based tumors. Sometimes they've already been operated on, and like most sarcomas, they just don't want to die. So eventually sarcomas can come back, and that's when you really need good imaging, a good radiologist tell you where the margins are. Is this resectable? Sometimes you've done that resection, and like, how much more of this person can you take? So we have one right now exactly like this, where they have a recurrence right next to one of the screws, but now you're going into a previously operated, previously radiated, hostile environment, and you want to preserve as much of these people as you can. We talked a little bit about custom implants. We work with the device companies to make custom implants. Most of our the companies can't do these sterilizable fit tests. So we do a lot of sterilizable fit tests. We do a lot of pre-bending of stuff, because that costs about 60 grand in the United States. So your plan has to be right, and it has to fit, because you sign a whole stack of documents that say, yes, I will pay for this if I do it. But when it fits, it provides options that you don't have. For patient experience, especially with our skull-based patients, we have a lot of patients say, can I get the model? Can I have the model? Can I get pictures of the model? So we're always printing little versions of models along with our other stuff. Because if you put more jobs on the printers, it doesn't really cost that much more. So we talked about informed consent earlier, but like in the office, the thing I love about this picture, and that's Mo Biden, who's now at University of Chicago. What I love about this picture is no one's talking to the computer. That here's a patient, here's their skull, here's their tumor, here's their spine. He can wrap his brain around that. And you're having a real discussion about swallowing, trachs, peg, like all the things that would come with a jugular frame and tumor you're having with a patient who can ask questions, who can talk in some vehicle along with you so you can understand what's happening. And then if you want to use it in the OR, you can use it in the OR. We talked a little bit about class 2 devices. I would say for this, and this comes up for what we're going to talk about for meningiomas, because we do about 300 of these a year. We do another 200 maxillectomies a year. And it's just bread and butter every week, all week. We're cutting out someone's mandible. We're creating custom sterilizable guides. We're creating patient-specific things that screw onto patients' mandibles, that screw onto maxillas, that resect through submaxillary insections, that screw onto the fibula. We map all the perforators. We have custom titanium plates. It all fits perfectly back in someone's mouth. And that saves $9,000 every case before we even bill, before we have billing codes. That's in the US, that saves $9,000 just operative time. And we've published no takebacks, no hardware failure. We've published all the data that proves beyond just the cost savings what the real savings are. We have a number of patients that come here for fibrous dysplasia. So we have all sorts of guided systems in order to say, how much can I just lop off without getting into the inner table? Can we mirror image things to make it right? Can we just create cutting guides so you can just screw on here, put saw in, don't worry, you won't be through the inner table. You can just start taking off large chunks. We do a fair amount of craniofacial anomalies. We have 3 cranial synostoses going on right now. One's just a metopic, one's an orbital bar advancement, one is a complete pancranial synostosis. But we plan all of this ahead of time before you get there. So there's really no surprises, whether it's in the maxilla, whether it's in the skull base. And that translates. So a lot of what we do in one specialty translates to another specialty. So we have these exophytic tumors that we were really having a lot of skin burns, and you'd have these transcranial things growing through the skin, through the eye. And our radiation oncologists we work with for a number of reasons came to us and said, can we make we were making step-off boluses for them. And they said, can you make exophytic tumor step-off boluses? And for us, that's simple. Like, oh, you want us to minus a patient's geometry out of something we manufacture? You're like, no problem. That's the easy part. For us, they said, oh, well, who's going to do all the radiodosimetry and who's going to do all the... They said, no, that's what we do. So you take those 2 groups of people and you just put them together, and you get something magical for these patients. So this one's growing out through her spine, out into her mouth. It's an incredibly challenging place to do radiation to. We've had really good success of not having skin burns, of being able to take mini collimator. I think we're up to like 62 now cases. And it's because the door is open. And it's because we talk to each other. And it's because we have class 2 medical device manufacturing. And it's because we're a multidisciplinary place where the needs of the patient is really the only thing that matters. So if you take somebody like that on day 0 and can get them to something like this by day 19, and manufacturing has a role in that, it's incredibly rewarding. And because we have this system of working together, I think it's really important. So when someone says, hey, sometimes I don't need you to redesign the whole skull. I just want to know in this patient, where is the veins? So they say, oh, that's easy for us. We can just give you a little vein guide. We'll just map out the veins on the non-con. You don't have to give contrast. And then we'll just give you a little guide, and it's just like, to us, that's, yeah, it costs money to do the planning and stuff, but this, we have like Python scripts going now that it's just super fast. We have an AI algorithm does the skull. We have Python scripts, makes the guides. All you need is a radiologist, really, or a good technologist to do the veins. And that leads to more complex things. It certainly leads to simulators. We have 2 special effects engineers that are building complex simulators for us. What's it like to do transnasal approaches in pediatrics? What's it like to nick the carotid when you're doing a transphenoidal? What's the protocol for transphenoidal carotid injury? Like, what does it look like when all the blood's pouring out of the mouth and nose? So we have special effects engineers that take our 3D printed stuff and make other things. And then we have this cross collaboration. So we were doing a lot of things off the teeth with radiation. We were building dental molds that tie into the proton beam, dental molds that tie into the gantry for people who can't have fixation. And one day, one of the ENT surgeons, the plastic surgeon we're working with, was talking to Kendall Lee, and he says, well, why don't you just use the teeth? Because we're doing all this stuff with radiation in the teeth. And Kendall came upstairs and said, can you guys make us guides for the teeth that we can potentially navigate out of the teeth? And if we can navigate out of the teeth for certain things, we can skip the O-arm by scanning the face. So we went from like an idea, drawing on the board, to like, I don't know, a month and a half of coming up with new ways to try and build solutions that you can potentially navigate with the Medtronic pump hooked onto the teeth. And because we have done so much work with affixing things to the teeth for mandibulectomies, for radiation oncology, that for us, we knew the tolerances, we knew how many millimeters, we knew how it would stick on the teeth, we knew what material to use. Like, we didn't have to recreate that. And then you get to a place where you're starting to do like, well, let's start with something easy. let's start with a small meningioma next to the superior sagittal sinus. Let's start with navigating, see if we can get away without the O arm. And it's because of this cross-pollination, this collaboration. Like, can we do custom boluses for intraocular melanoma? Like, because someone asked the question, what if? And we have built a manufacturing infrastructure about 10,000 square feet and engineering sciences that when they say that, what if, we can respond with something that allows us to have better patient care, and they take care of the other stuff. I'm not an expert in neurosurgical navigation, but I know Kendall Lee is. He's done everything and built an entire company on navigation, So just like the radiation, people know all the radiation, which moves us a little bit into augmented reality because we started working with Magic Leap in the early years and HoloLens One and just projecting data above the OR, and then other companies come along like MetaViz. Mayo Clinic's an investor in MetaViz. I'm not an investor, but Mayo Clinic is an investor in MetaViz and MetaView just for any conflict that would arise. But we have people that are, where is the jugular vein in this person before I put the pins in? How much do I have to rotate the head? Can I do it 15 degrees like this? Like, where do I want this to be? So we've been partnering with some of our neurosurgical colleagues like Giuseppe Lanzino and doing complex AVM, and how big does the flap have to be? Where does the craniotomy have to end? How big can you make it? How small can you make it for something? So there are other companies, obviously Leica Microsystems developed their own augmented reality that lives in their system, which is incredibly robust. But for us, well, we already talked about that. For us, like printing stuff still has value because even with augmented reality, there's still no haptic perception. And there's just been this super high-end value of haptic perception of people touching things and feeling things, whether it's the surgeon or the patient. I'm going to talk a little bit about education, then I'll end. We have 3 shields at Mayo Clinic. The upper right one is education. 70% of our staff comes from us. So I serve as the executive medical director for immersive and experiential learning, and we're building entire virtual reality education applications, augmented reality applications. We have about 5,000 or 6,000 learners at any given time, including neurosurgery residents, including all the allied health that you can't operate with. So a lot of the 3D printing stuff goes all the way down to the medical school, goes all the way down to the schools of health science, goes all the way down to allied health in order to teach people anatomy. Because we have this medical knowledge, we have this 3D printing ecosystem, and really we've been trying to reuse everything we can. Like behind me are all patients that are now up for craniosynostosis education. And how can we reuse all our patients in order to teach people spine development, in order to teach people what a 1-year-old spine is? How do we support our CPD efforts? So yes, we're making these cases and segmenting, and we're creating these robust models, but how can we then create an entire virtual reality ecosystem by taking that data, putting it through artistic pipelines with our special effects engineers, creating more realistic things? And then when we have people come here or we go places to teach people, can we bring all of our approaches? Can you go through far lateral, through suboccipital? Can you look at this in the operative position? Can you decide like, hey, here's a hemangioblastoma. What approach would you choose? Would you choose, and then we've done every approach. So we have every approach that we show during the endoscopic skull base course that Maria Paracelda puts on. So they get lectures, they get 3D anatomy, and then they can go through virtual reality training, and then they can go to the cadaver head on the table every day. We can look at images while we're in here. And virtual reality really opens up the endless possibility of unlimited monitors, unlimited time. And while people think it's really new, this is a picture from 1897, which I love. One, because it's radiology, and I'm a radiologist. But 2, the idea of looking through a person in augmented reality or looking at something virtually, that's as old as time. As soon as Wilhelm Röntgen invented the X-ray, the very same year, people published reports of digging bullets out of the hand using the X-ray. So people have wanted this augmented reality ever since we could look down through a patient. So that's an X-ray generator, that's an II. So you can imagine all these people died of bad radiation cancers, but the idea is not new. The idea of wanting to practice, the idea of wanting to look inside, the idea of developing things is not new. We talked about some of the education for simulating rare events. So we create things like, how do you simulate carotid injury? How do you do it when everyone's happy? Nobody's happy when there's a carotid injury in the OR. But when you're doing it in a simulated way, everybody's controlled, happy, take a little bit of tongue, crush it up, put it here, start the high transfusion protocol. You can do it anywhere. And then we can do it as many times as we want. So I think what we've tried to do with manufacturing, and particularly as it relates to neurosurgery, is we try to have people think beyond the obvious. And that's not new to anybody at Mayo. That's part of the culture here of saying, what if I did this? What if I did that? And we try and bring infrastructure and technology to those questions in order to say, can we make this better? Can we help this patient do this better? And can we increase the circularity of model by building all the infrastructure it takes to do this? Because like pictures like this are a little ridiculous. No one's holding controllers with sterile gloves, right? I mean, you have to build specific staff. You have to build specific implication. You have to build VR engineers. You have to build special effects engineers. You have to build deployment areas that are part of the very fabric of Mayo Clinic if you're going to do this type of work. We have a whole other host of 3D printers that do research in the Department of Engineering. We got another 2,500 square feet of additive manufacturing that does research. So we do a fair amount of research using additive manufacturing. It's been one of my roles to try and create national infrastructure. So we've created society, journals, national IT infrastructure, billing codes, quality control standards, regulatory frameworks. You know, if you order an anatomic model, can we bill it? Well, that needs a CPT code in the United States. And how are those codes going to be distributed? Right now, we have a multi-part model. We have registries with the ACR. So if you do this and manufacture it, you can bill for it. You know, so I think, you know, if we've tried to do anything, it's that if one of you out there has a desire to change your practice and use some sort of technology, be it augmented reality, virtual reality, a new microscope, some sort of technique, you know, it's so much more powerful that when you do it all together as a team of people. And I think I've tried to show how cross-pollination between all of these disciplines really has led to advancements in neurosurgery. So I'll kind of end on that note. I was rushing a little bit, but I still try to get it in by 11.
Thank you, Dr. Morris. Thank you very much for your presentation and for joining us and for delivering the speech, which was really incredible. Also, the technology that you have presented is absolutely fantastic. And unfortunately, not many centers can afford probably this kind of infrastructure, this kind of technology that you have already developed. I have tons of questions. Unfortunately, we don't have any in the Q&A box, but due to time reasons, I think we should proceed. And I think Nikolay will close the webinar now.
Yeah. Well, if anybody wants to ask some questions, I don't have to go either. But you know, when you said afford, it's really interesting because a lot of people talk about the cost, and no one talks about the cost savings. So if you do a mandibulectomy and you have to take the patient back because of a flap failure because the flap was too on, that's another 30 grand in the United States. So not only are we saving 9 grand per case, then we're billing through the AMA, and then we have less than 2% takebacks right now across all 3 campuses in craniomaxillofacial, you know. And if you're doing something that allows people to come to your center, it's also financially viable. Like in the United States, there's competition, right? You have to fly over a lot of amazing hospitals and surgeons before you get to Southeast Minnesota. So when we put that type of craniomaxillofacial down in Arizona, for example, we had to hire 3 more surgeons because we got so busy because nobody was doing that in that area. And then we just gobbled up all of this market share. And now all of a sudden we're running 3 more ORs doing nothing but craniomaxillofacial reconstruction. So the money part is a big picture. There's reimbursement, there's cost savings in the OR, there's less textbacks. In orthopedics, every 15 minutes to 30 minutes is an infection risk. So the cost of an external hemibullectomy infection is astronomical. So all of these things have to fit into a complex cost equation before people say, I can't do this. Like when we were in Hong Kong and Singapore, we have all these questions. Every country I visited that have set these up, they have all these questions. How much is it going to cost? How much is it going to cost? And you say, well, that's one part of an equation, right? And you say, like, what if you don't have it? Like, how much does it cost? And so the cost is more complex than just how many printers do we have, how much staff do we have. It's really like the bigger picture.
I think that here we have 2 very important messages. First of all, Thank you for this amazing presentation. I would say it's a little bit depressing because all of us more or less do some kind of 3D printing, but this is a completely different story. So, of course, you have a huge team, and I think that the main message should be first, this is possible. I mean, what we saw here are completely new dimensions of possibilities that 3D printing is giving to us. So for us, this was a good opportunity to see it by ourselves. And second, this point of view that in fact, as an investment, probably it's not cheap, but at the end, it gives you the opportunity to have better quality of your treatment and less expenses because of the faster surgery, less operative time, less complications, etc. So I was thinking about 3D printing as democratization because more people could do things that are more affordable. Of course, we have to invest in this, but you just shown us that it's really worth doing it.
Yeah. Well, I think too, like, remember, I didn't start here. Like, I started at NIH with one printer at Bethesda Navy, and I was doing medical school. I wasn't doing it. I had no idea what I was doing. I was like in medical school. Somebody invested in me and said, "Do you want to learn this?" I said, "Oh, yeah, I wanted to learn it." And we were doing pedicle screw trajectory guides in like 1998, 1999, you know. And there was somebody over there who had a passion for it, who wanted to use this. So when Scott Crump's wife, there's two technologies that started in the 80s, SLA and FDM. You can buy a bamboo FDM printer right now for like $4,000, and you can have software that's really cheap. A Formlabs is $3,000. I mean, a lot of those guides I showed you come off of Formlabs, and it costs material costs, not all the qualification costs, quality control. Material costs are actually quite low. There's a gentleman in Western India. They had no congenital heart surgery, none. The child was sent home to die. And they had somebody said, "No, I'm going to start." And then we collaborated, and he collaborated in the US, and they started making these hearts to let the surgeons understand the anatomy. And then people said, "Oh, I think I can do it." You know, it allows you to take on more complex cases too and have better outcomes. And then you build on that. And now the first kid they saved, actually, he was here a few years ago. The first kid they saved, just because someone understood the anatomy, works running that 3D printing center now in that part of India. You don't have to start with this. You have to start with like a passion to help patients. If you think the technology can help, you have to have a passion for the technology to help, because the technology is just a slave to the patient's needs, right? It's interesting for sure, but without I mean, I was doing this 8 years with no time dedicated to it. And it was only because the surgeons who were really good came and said, "Oh, that's really helped me. Oh, that saved my bacon. Oh, I went so fast, you wouldn't believe it." Or that really changed the way I put them on the table. It just, I would have been like operating like this, and so those things kept coming right out of the OR, and you'd say, "Oh, well, we'll keep going. There's something here," but it doesn't take like all of this. Sure, some people like Emory just built a new hospital. They're putting in 5,000 square feet. The VA built a new center in Cleveland. They're putting in 10,000 square feet. Like, we've got to the point where people believe in it. But to be honest, that guy in India bought a really cheap FDM printer, one color, and he just had a passion, and he didn't like the fact that kids went home to die. And then that changed the way it was done there.
Thank you very much, Dr. Morris. It was impressive, really thrilling. We had to think a lot about all your messages and all that you just shown to us. Thank you very much. Thank you for being part of the ETIN webinars. And thanks to all of you that watched with us this webinar and stayed with us. I'm wishing you a very nice evening, and see you next time.
Thanks for all your patience.
Thank you very much. Thank you. Bye-bye.
Thank you. Bye.